Hello, everyone. Good morning, good afternoon, good evening. Thank you all for joining us today from wherever you are located. My name is Sarah Jane Demy, and I am the CEO and founder of Demy-Colton. And I am located in New York City, as it says up on the screen. It is my pleasure to welcome you to the 12th installment of the Demy-Colton Virtual Salon Series, COVID-19, Surprising Cardiac Findings and Concern about the Potential Impact. As some of you know, Demy-Colton's mission is all about convening biopharma and digital medicine industry leaders to catalyze change. We know we help drive innovation when we bring individuals together who are united by a common cause and a shared passion. And in our industry, that cause and passion is bringing therapeutics and cures to people in need. As those of you who have attended past salons know, Demy-Colton was in the process of launching BioFuture, our new international business development and investor conference here in New York City, when COVID-19 came around and changed everything about what we do. So in lieu of an in-person BioFuture meeting, we launched the Demy-Colton Virtual Salon Series to continue our mission of bringing people together with great content. In the spirit of convening people, I would also like to mention that we will be holding Biotech Showcase digitally. It's now in its 13th year. Biotech Showcase has become the premier investor and partnering conference for private, small, and mid-cap companies. And when we're in person, it takes place alongside the JP Morgan Healthcare Conference. We invite you to join us, present your company, and register to meet the other participants virtually. We also have a really great program. Before we get underway, I would like to acknowledge and thank all of our sponsors for their support during this uncertain time. At Demy-Colton, we believe the Virtual Salon Series will be here to stay even after we get beyond COVID and get back to a new normal. Please check our website for the schedule of salons, fireside chats, topics, and participants. It is evolving constantly. And of course, I invite you to join us at future events. A note about the structure of today's program. The formal portion will last about 50 minutes, and it will be followed by a 15-minute Q&A period. You can submit questions in the Ask a Question pane, which is located below the screen, and we will address as many as possible. And it is easier to address questions if they are as concise as possible. Please note that this salon will be recorded and will be available for on-demand viewing a bit later today. As I mentioned earlier, today's virtual salon is titled COVID-19, Surprising Cardiac Findings and Concern about the Potential Impact. Our panelists today are Dr. Bob Hu of Sutter Health, Palo Alto Medical Center, and Heart Vista, Dr. Eike Nagel of the Institute for Experimental Translational Cardiovascular Imaging at the University Hospital Frankfurt, and Dr. Eric Topol of Scripps Research and the Scripps Research Translational Institute. Please note the disclosures that should be showing on your screen for our panelists. And I'd like to say welcome to all three of you. Thank you very much for joining us today.
Thank you for having me.
My pleasure, my pleasure. So I'm going to briefly go through your bios. Dr. Hu is, as I mentioned, is Director of Cardiac MRI at Sutter Health. He is a board certified in cardiovascular disease and internal medicine. His interests include non-invasive cardiac testing, cardiac imaging, and cardiovascular magnetic resonance imaging, or MRI. And he is also a co-founder of Heart Vista. Most people, when they list what their interests are, say, biking or something else, and yours is not quite like that, Dr. Hu.
That's
Dr.
my TV you've just read.
Sorry. So Dr. Eike Nagel is a professor and director of the Institute for Experimental and Translational Cardiovascular Imaging at the University Hospital Frankfurt am Main. Dr. Nagel is a pioneer in the research and clinical clinical use of MRI of the heart. In fact, in a groundbreaking 2019 paper, Dr. Engel and an international consortium were able to demonstrate that patients with stable chest pain can be assessed and managed as safely with non-invasive perfusion MRI versus invasive cardiac catheterization. And more recently, Dr. Nagel and his team also published a study of recovered COVID-19 patients, which attracted considerable attention. In fact, according to Doctor Who, it woke up the cardiac world. So we will be talking about that a little bit later. And Dr. Eric Topol is a practicing cardiologist, scientist, and author who is the founder and director of the Scripps Research Translational Institute and executive vice president of Scripps Research. He has published 3 bestseller books on the future of medicine. His latest book, Deep Medicine, focuses on the impact of artificial intelligence in healthcare. He is also one of the 10 top most cited medical researchers in the world. And as I mentioned to you earlier, I must admit, The Doctor Will See You Now is one of my favorite. And in particular, because I think the title just grabs you, especially if you're one of those people who doesn't like spending hours waiting in a doctor's office or dealing with all the other challenges. So let's move on to the session. What we wanted to do with this discussion was position it as a public service announcement. I know that there has been a lot of writing and commentary about the long haulers or the long COVID patients, people that have had COVID but don't seem to fully recover. And the fact that they don't fully seem to recover leads us to part of what our discussion will be today about potential damage to other systems. Part of the discussion that we'd like to refer to and is the slide up of the COVID damage. So we have, hold on a second. I'm getting to the data, which I think we'll refer to. So globally, there are 55,472 reported cases of COVID. And globally, there are 1,335,000 deaths. And of those, globally, 35,600,000 have recovered. Something wrong with that number. And in the U.S. alone, we have 11,320 confirmed cases of COVID and 248,000 deaths. The reason that these numbers are important and they change daily is because what our discussion today will focus in on those people that have technically recovered from COVID, whether it's mild or severe, and the potential damage done in this particular case to their heart. So in fact, today in the New York Times, there was a story that was published about following up with exercise after COVID-19, and doctors from the Hospital of Special Surgery here in New York City said that you need to take it slow and to be checked out. This is in addition to all the various articles that have been published over the last few months outlining the continuing malaise, if you will, of people who have recovered from COVID-19. We've heard of athletes who were not able to continue their previous level of performance. We've heard of people that were regular runners who have had heart attacks and died after COVID-19 because of unanticipated sequelae, I believe is the word that we would use. So Dr. Topol, I would like to set the stage for our discussion by asking you to comment on the October 23rd article that was published in Science magazine, where you state that the family of human coronaviruses are known for their impact on the lungs, not the heart, or indeed not on other organs, including the kidney or liver or other systems. Would you describe those findings for us?
Sure, Sarah. Well, first, let me just say the book was The Patient Will See You Now, not The Doctor Will See You Now, but that's okay.
Oh, my God.
Now, that was the flip, of course. Now, with respect to the science review of the heart and COVID, the point you're getting at here is that the other coronaviruses, the 4 common cold coronaviruses, and SARS and MERS, have never had the extent of heart involvement that we are seeing. Now, part of that is because, as you reviewed, the universe of people infected is enormous. It's far greater than 40 million, and maybe 200 million, or who knows how many at this point, because the number of confirmed infections is a tiny fraction of the actual infections. Mm-hmm. So there was some heart involvement in SARS and MERS, but that was minimal and different than what we're seeing with COVID. COVID is causing a diverse array of many serious manifestations. And the only debate is how common they are and how much do they attribute long-term to what will be cardiovascular morbidity or mortality. So the issue here is that we didn't anticipate it. When this came into the world, it was considered a respiratory virus. Yeah. And it was only a couple of months in did we start to recognize the heart story, and it's still unfolding. I mean, it's still every day we're learning more about the COVID and heart involvement. There's lots of unknowns that are really big unknowns that hopefully in the months ahead we'll be able to resolve. The point you just made about exercise, we don't even know that. I mean, we're telling people after COVID they got to take it easy and not exercise, and maybe they could have subclinical heart involvement. But, frankly, we're just drawing that from other viral myocarditis, not from COVID. Just so little is known at this point, relative.
Mm-hmm. Now, another point you made in that particular article is that you believed or suggested that COVID-19 may be structurally different from other SARS viruses because it attaches to the ACE2 receptors. And because it attaches to the ACE2 receptors, that means that it can penetrate the cells.
Yeah, so this is actually, I think, an important distinction. It is also a matter of some controversy. There are 4 induced pluripotent stem cell studies, one from Cedars-Sinai that was published, one from Mayo Clinic, and a couple others. And they all show something that's quite extraordinary. When you make heart cells in a dish from either white cells or fibroblasts, and you put in the virus, either the heart cells stop beating within a matter of hours, they get directly infected, fusion, these cardiomyotubules can form. All these bad things can happen. And in fact, what is different about the heart cells in a dish is not the same as a heart organ in a body of a person. It's more like a fetal heart, and it's not obviously, completely the facsimile of but you can't do those kind of experiments in people, of course. You can't even do them very well in experimental models. So all that has done, these induced pluripotent stem cells, has made things more concerning because they show direct penetration of the virus into cells. The 2 big things that can happen is either there's just an inflammation, immune reaction to the heart, all parts of the heart, pericarditis, myocarditis, endocarditis, and also the endotheliitis, that is the blood vessels being inflamed. That's an immune inflammation indirect. The direct would be that the virus gets into cells, as you said, because it can attach to ACE2, which is expressed in the heart pretty densely, and do damage directly by hijacking the cells. I mean, just taking over the heart muscle cell. So that the potential is there. We know in some patients there has been, no question, virus getting into cell in the heart, in people. We just don't know how frequent that is and how much that is operational versus the indirect.
Okay, thank you. Thank you for that. Dr. Nagel, if I can switch over to you. As I mentioned earlier, I understand that the paper you published recently, I believe it was in July, really captured everybody's attention in the world of cardiology. Would you please describe your study, who participated, and what its findings were?
So originally, we had actually planned to look at what Dr. Topol just said, the direct damage of the heart through the virus. And we had originally planned to look at acute patients. It turned then out that we couldn't do them because the pandemic hit. The hospital resources were just overwhelmed. So we then decided to look at patients who had actually recovered from COVID, who were post the acute illness. And what surprised us then was to see that in those 100 patients we recruited, 78 had some kind of cardiac damage. Now, it is impossible for us to know whether this damage is due to COVID because we didn't see those patients before infection and after infection. But what we did is we matched those 100 patients to other patients, other people who had the same amount of risk factors, the same amount of diabetes, same amount of hypertension, same amount of lipid storage disease, and so forth. And we found that the number of patients after COVID who had significant damage or had some cardiac damage was much, much higher than in the control group. So from that, we can deduct that actually COVID does do some harm to the myocardium, to the heart muscle. Now, what we see mainly, I will focus on two major findings. One is we can, with modern very sensitive means like magnetic resonance imaging, we can see diffuse damage and we can see scar. Diffuse damage means there's something going on in the whole of the heart muscle. And that's mainly what we see there mainly is water. So as a sign of inflammation. And in 22% of the patients, we saw 5 standard deviations increased amount of water. And that's not something you find on an average person. That's not something you find on a person who has similar risk factors. That's a significant change. So 22%, we thought that is an enormous amount of significant change. And in 20%, we found scar. So irreversible damage in certain parts of the heart muscle.
And that's all within this group, this cohort of 100 patients that you studied?
Yes, that's in the 100 patients, and 33 of them had been hospitalized before, and the other 67 had relatively mild symptoms. It's difficult to say whether people were completely asymptomatic. If you ask someone backwards, did you have headache or muscle pain, or did you not feel well over the last 2 months? Most people will say I had a day or two where I wasn't that well off. So we can't really say they were completely asymptomatic. But quite a few of them were spouses, family members of people who had COVID, got tested for that reason, didn't know they had COVID, but just had a positive test. And despite this relative fitness and relative low level of symptoms, we still found that large amount of cardiac damage.
I think that one of the reasons that your paper really caught everybody's attention is because if that number, if you extrapolate your findings to the global population with 55 million COVID cases, and as Dr. Topol mentioned, probably more, you mentioned probably more than that, with 35 million people that have recovered, what does this mean?
I think there are two things which are really important on that. The first is what we seem to see is not the effect of the virus directly. We seem to see something which happens after the severe, so more an autoimmune response. And that's important because it's not the patients who are acutely ill which have the problem. They have also a problem. But that's a different problem. But those who have recovered, they develop an additional problem due to the autoimmune response. So I think this is important because it can also hit you a couple of months after you actually had COVID. And you can go in waves, you can get better and worse. And we see lots of dramatic stories there. But answering your question, if we just assume that about half of the patients get tested or have some kind of symptoms, and we assume, and that's an underestimation probably, and we assume that only 20% of them have some cardiac damage, and again, that's an underestimation of what we have seen, we end up with about 10% of those who have COVID having some cardiac damage. So if you say there are 1.1 million US cases with COVID, that would mean 11 million cases in the US, that would mean there are 1.1 million cases who now have new cardiac damage due to the virus. And worldwide, that's 5.5 million people or more.
And then, of course, the question is, what burden will that be on society? You know, the first thing is, do these patients need to be tested? If they are tested and you identify the damage, are you able to treat and mitigate the damage by identifying it?
Well, this is a short question with loads of things and requires a very long answer. I will start with a shorter answer. Is what we find or what we have seen relevant? We don't know for COVID because we don't have the long-term outcome. We can only deduct from other patient groups. But what we know from other patient groups is if they have the kind of scar we see, if they have the kind of inflammation or water accumulation we see, then the percentage of them which have a bad outcome, which have develop heart failure or develop arrhythmia or develop premature death, is significantly increased. So what we see is relevant. It's not relevant maybe on the individual basis to say a patient who has this kind of damage will develop heart failure. But on a statistical level, it's clearly something which, if what we see in other patient groups holds for COVID, which I think is likely, then it will have a significant influence on how cardiac health will develop over the next 10, 20 years in the general population.
Dr. Topol, I'd like to ask you to weigh in on that. As a practicing cardiologist, what do we need to do as a population?
Well, we have to do a lot more research, like the work that was just described, which is terrific. But what we don't really know at this point is the extent of the problem and the natural history. So, you know, we need more follow-up. We don't have enough, you know, with controlled series, ideally with MRI or echo. You know, we've had several reports, you know, where it's only people with COVID, but we need better studies. There have been some with controls, but we need large studies. I mean, the potential here for myocarditis, cardiomyopathy, myocardial injury, or even just the arrhythmias. We've seen a sudden death in a professional athlete, and we've seen other people with serious arrhythmias. So the problem here is it could be not as concerning as it looks right now. There were 2 autopsy studies published in recent days that suggested that myocarditis was only focal. It wasn't, you know, generalized. That's good, but that's a select group of people who died. And that's only, you know, part of the story. So we're still in the early days of understanding this, unfortunately. And it looms large because, you know, we could be seeing people in the years ahead, as I pointed out in the Science paper, where they have a weak heart. I mean, they have a real full-blown cardiomyopathy. We don't know why. They're positive COVID in terms of viral antibody testing. And we don't know if it's true, you know, related or unrelated. That's what we have to figure out now before we start to see a lot of these patients in heart failure clinics around the world.
Right. Would you recommend? Oh, sorry, Dr. Nagel, go ahead.
Yeah, I just wanted to add what's really worrying at the moment. I fully agree with what Topol says, but what's really worrying already is that we see these changes month and month and month after the infection. It's not only the next 2 weeks or next 4 weeks. We examine patient 3 months, 6 months, and now we have the first 7, 8, 9 months post-COVID patients, and we still see some kind of cardiac involvement. The severity of it, the relevance of it, I don't know, but we still see something.
All right.
So the next question.
Yeah, I agree. It's happening. We just don't know the frequency, but it's absolutely true. And long COVID, some young people, healthy, mild COVID, and even some asymptomatic athletes now can have what was just described months later, unwittingly, only detected by a scan. So that is even more concerning that people don't even know it. It's just like what we saw with the lungs. If you take people without symptoms of COVID, they've had an infection, they never had symptoms, and you put them in a CT scanner of their lungs, about half have significant abnormalities consistent with COVID. And that may well be the case with heart. We don't know. That's the issue.
I know. I think it's the unknown right now is really quite frightening. We'll follow up, a little bit toward the end about what's being done right now to undertake studies to assess patients, because the long-term effects can be a huge burden, not just in the United States, but on a global basis. So I'd like to move over to Dr. Hu. And on Monday, we spoke about the need for standardization and testing, as well as the need to deploy diagnostic testing that employs AI, which will help make testing, in this case, an MRI, much less burdensome on multiple sides. Less time-consuming and less expensive, for the healthcare system. I don't know, do you want to bring up your slides now? Are they ready? Should we go to that? Or because I'd like to get to under what conditions would you start to recommend that people get MRIs of their hearts? I think that's an important question. We couldn't hear you.
I stopped because there was an echo earlier.
Okay.
Yeah. So I'm sorry. So I was going to say that if the slides are ready, maybe bring up a couple of them just to, I think, have some visual aid in discussing this issue. As Dr. Nagel and also Dr. Topol has already said, our problem right now is that it's potentially a huge problem. And but although we don't at the moment know exactly to what extent this will become an actual clinical issue. None of us want to sound alarmist, of course, but at the same time, we don't want to duck any issues either. And probably the most important first step in the evaluation and treatment of these patients is, as Dr. Topol has suggested, we need more research just to kind of define the problem better. And a smaller sampling in the beginning is helpful, and perhaps intensively studying a smaller sample of people will give us the kind of clue to help us decide on how big an issue this will eventually become. Just to, if that slide is up, I can't see it. This is a very short study over the course of literally, I think, about 3.5 weeks that was done in Italy. And what they did was just basically took every patient that was discharged from the hospital. And as you can see, the mean age of these folks was just 56. So pretty young, actually. We talk a lot about people who are older. But look at this younger group of people who were discharged, and 147 of them. Their follow-up started on average 60 days. And so as Dr. Nagel has mentioned already, these are late, folks. And even at 60 days, only 12% of them were actually symptom-free at that point. Fatigue is a little hard to describe because a lot of people feel obviously fatigue from any kind of illness. But shortness of breath, 43%, chest pain, 22% roughly. These are very important findings, and it echoes what Dr. Nagel's own research has shown in terms of the type of people who have symptoms. This is not all comers. And so now we're talking 20% of potentially all comers who have recovered, who may have symptoms. And would you at that point then want to do some sort of evaluation to understand what this means? If the research that's being conducted by really, worldwide by a lot of folks shows that this type of problem is going to have long-term consequences, then we would need to, shall we say, find the people who really have heart involvement, number one, and number two, with that more directed evaluation and cone down to people that we can then intervene on and make the problem really more manageable. Because otherwise we would be saying, okay, let's treat 50 million people, right? So so even if it's just 10%, as Dr. Nagel suggested, or even 1% of the patients who ultimately require treatment, the number of studies that are necessary to study the heart is potentially ginormous, to use a Google word.
It's an official word.
Yeah.
It's an official word.
And so here we are, okay? And Dr. Nagel could actually, attest to this. MRI, cardiac MRI itself, just any kind of cardiac MRI itself, is normally a fairly time-consuming study, okay? And it requires a lot of training of the technologists to perform them, to acquire the appropriate data. And it requires, obviously, expertise in analyzing the data that's been acquired and then drawing conclusions. So it's a laborious process all around. Standard cardiac MRI easily can take upwards of an hour to do. And obviously, as I said, limited by the availability of trained personnel. So our approach for cardiac imaging in the last few years has been to employ, obviously, artificial intelligence to try to minimize, if you will, or aid the technologists in the study of these patients, so that we could eliminate some of the variabilities between human operators, as well as simplify the workflow for them, so that there is not an intensive need to sort of do exactly the right thing across a number of people who were doing the scanning for these patients. And we've been trying to learn from Dr. Nagel in terms of how his human technicians are actually, acquiring this kind of data. And then in turn, we're taking that information, along with, other folks, to try to understand what's the best way to train a machine to do this. And in so doing, we hope to be able to make the method widely available to essentially every place where there is a reasonably good MRI machine, and allow the technician, take some of the burdens off the technician in terms of actually doing the scan, and then finally present good data for analysis to the physicians who actually have to care for the patients. Our work, and I'm not sure, I don't think, unfortunately, our video is working today, but our work is such that we're reducing the typical exam of a cardiac MRI from maybe 200-300 clicks to kind of manage the entire exam down to just a few, 3, 4, sometimes none, sometimes one to get it going, where the machine is looking at the pictures, making the decisions about how to acquire the data, and then acquiring it, and then looking at the quality of the images that are acquired and deciding on whether these are passable in terms of quality. And then finally, when we're able to get good quality images, to then make some analysis, preliminary analysis that will aid a physician. So that's why we think that AI will be helpful. And in doing all of this, we're hoping, obviously, to make not only the workflow manageable, but also really the cost, which is a big factor. It's already hurting us in so many ways. We don't want the scan itself to become, one more huge burden on the medical system.
Yeah, no, the cost could potentially be untenable. And of course, the follow-up question to that is, what will the need be to monitor patients who have recovered from COVID-19 out to 3-4 years? And I know that the cardiac involvement is, major and quite important, but in all the literature that's been written about it, I've read about, blood clots, other organs being damaged, people losing limbs, because of clots in legs. So I think what's happening on the cardiovascular side is also reflective of what may be important for other systems, so to say. Do you have an opinion of that? I want you to give us a precise answer, which I know you can't until there's research done. I know everything is still an unknown, but your educated guesstimate.
So let me start off with what is actually demanded of us, okay, what's asked of us, I should say, which is that our referring physicians, right, who are looking at folks with patients with symptoms. That's generally the thing that drives the evaluations. If there are no symptoms, then I think it's a little, iffy at the moment in terms of what's the, do you go and scan everybody, right? That's a true research question. But if there are symptoms, then you can't really ignore that, right? You and I have chest pain or something of that nature. And so that's what we are currently in the clinic seeing, is that people are coming in because they have symptoms that you say could be a cardiac related complication of what's going on. And there, unfortunately, the number could be as high as 20%, as I was saying earlier, on these post-discharge patients. So we are all already seeing, more folks who are in need of being studied. How will we end up in a situation where where we will actually begin to have to triage some things ourselves? Most of the time we think of triage as something that happens in the acute setting of, someone sort of sitting in the emergency room and the doctor is going bed to bed deciding on what to do. But resources of, sort of high-end scanning can certainly easily turn into something like that. And I will unfortunately have to duck and say that, we're all trying to acquire as much data as quickly as possible to overcome that. But the answer still lies in research. As Dr. Topol, again, I'm going to refer back to his statement earlier. That's what we need.
Right. Dr. Topol, would you like to add to that?
No, I think that summarized it pretty well, really. Bob has nailed it. I think the unknowns here are overwhelming. But we have to get our arms around this. It's vital. Not enough attention is being given to this area right now, I have to say. Several groups are working on it, but they're doing it bootstrapped without funding, just because they know it's important. And we have to get all over this. Everything here is a big question mark.
Who would go to for funding? Is this NIH funding that would be needed to support it, WHO?
Eventually, they'll kick in, but it takes time. First they have to be receptive. That usually means they have to develop their own RFA to invite funding. And then there's the review cycles. And there's a little bit of distraction right now. It's kind of like survival.
Yeah. Right.
So, it's slipping. It's definitely slipping. The groups that have gone after this have done some really great basic science work, in the dish. It's been terrific. And there's the imaging studies. There's the pathologists. But there's no big study. Like for diabetes, there's a COVID diabetes where there's an international registry of all new onset diabetes. We don't have anything like that for the heart. And it's just as important, if not more. So, some other areas have been able to cull together the funding and the organization to have an international registry of all the patients that they detect and sub-studies on those patients. We need something like that. You have any rich uncles that you could suggest, Sarah, that we could get support?
I'll work on that.
Okay.
I think one of the things that we can do is, of course, again, go and publish, a piece based on this particular conversation. Dr. Nagel, would you like to add to that?
Yeah, I think that there are two things which are really important. One is to continue and to increase the research which we're doing, and that's the A and O of everything we do, because we just have too many unknowns. On the other hand, we should, what we do now, try to base it as much on science as possible, and as much on also knowledge we have from previous experience from maybe other diseases, try to deduct and try to translate. And that's why I would like to come back to the standardization and to what Dr. Hu said about scanning faster and making it all happen. That's why we also work together. We have scanned with a very specific system. The go-to-CVI approaches is how we call it, which is a highly standardized system. And we have experience in several thousands of patients, also multi-center data. And because of that, we can also deduct from other patients with non-viral myocarditis, with other viral myocarditis. We have outcome data on those patients, and we can then transfer that data to the current problem. And we don't know if it's one-to-one, but at least we know there are similarities, and that also allowed us to match the data. So I think two directions. One is to increase the research, and the other is try to collect everything we have from previous knowledge to make our assumptions as scientifically as possible.
I think the job ahead to get attention, as Dr. Topol mentioned, and as you mentioned, Dr. Nagel, is going to be quite difficult, at least until we probably get through the distribution of vaccines for COVID. I think hopefully the federal government in our case would be amenable to paying attention to this, at that time. So, a few questions did come in as we were preparing for this, and I think we may have addressed at least one of them. And Dr. Nagel, this would be for you and probably also for Dr. Topol. Can you address the incidence of myocarditis in recovered COVID-19 patients versus a healthy population? So a population that did not have COVID versus one that had COVID, what is the incidence? I'll just start with what I think. So the one thing which is really important for anything I say when I really answer this is the definition of myocarditis is unclear. Myocarditis is perceived by many people as a deadly disease, which hits an athlete in the middle of the game and kills them on the spot. And people think that all the other myocarditis heal with no long-term damage. And people don't really see that there's a huge width of myocarditis. It's the deadly one where people come with heart failure immediately, and there are the slow ones which burn over years and develop heart failure, and then there are the ones which heal. So that's important because people have completely different understanding of it. And so far, myocarditis was always diagnosed by biopsy. You had to make a biopsy to make that diagnosis. And that is somehow changing at the moment because we can't biopsy the whole population, or we can't make large studies based on biopsy. And that's where imaging now comes in because the methods have developed over the last years. But we see something different. We don't see necrotic cells. We don't see the virus. We see damage on the heart. And that's important when we talk about myocarditis. So when I say, what's the incidence of myocarditis? I can only say, what's the incidence of damage of the heart due to inflammation, due to increased water, and due to increased fibrosis. And that's something we see in approximately 20% of people who come to us after COVID. But we don't know how many people we miss because we don't know how many people had COVID without being tested, without knowing that they had it. But of those which come to us, approximately 20% have significant myocarditic damage. Wow. Dr. Topol?
Yeah, my number one question is, why do certain people have a propensity to heart COVID? So what I'm talking about here is, I alluded to it earlier, there are some people, when they get infection, the only organ that manifests the infection is the heart. And that's what I would consider as an extreme phenotype, meaning that we should get as many of those people as we can together and understand them at every level, particularly their genomics. But, you know, what is the reason why these people only get heart COVID? If we could do that, that will advance the field. And we know that, you know, from the various colleges that have systematically had small series, you know, from 40 to 80, 100 athletes, there are some of these athletes that the only thing they manifested without symptoms was as MRI abnormalities consistent with myocarditis. So there's something going on here that we don't understand. And it's elusive, but we know how we could get to it. If we could get enough people that had heart-restricted COVID, that would be a really big advance, I think. You know, whenever we're trying to learn something about an unknown entity, getting extreme phenotypes is a great way to start, because you can't study, you know, hundreds of thousands of people. You just study the ones that are outliers. And the propensity for the heart is we're not talking about people who are in the hospital with severe COVID, who get multi-organ damage. We're talking about people who are outpatients, had mild, moderate COVID, never got that sick, but then they show up, you know, for their MRI or their echo, and there's something really disrupted with their heart function, or they have clear-cut MRI scarring and myocarditis, cardiomyopathy, you know, all that. So that's what I think that's the study I want to see ASAP.
Yeah, it's, you know, I'm just thinking, you know, in my own case, I know of a young man in his 30s who had COVID, who was athletic, who was a runner, he had severe COVID. He wasn't on a ventilator, but, you know, he was quite sick for a period of time. He can't run. He can't continue. He can't pick up with his exercise. And I know one of the problems, I think, right now is that many people think this is a pulmonary disease, and they don't necessarily think that it's a heart disease. So if he goes to a doctor, his doctor will send him to a pulmonologist, not necessarily to a cardiologist. I think that's a message that has to get out there in a very big way, because, you know, how many people are we missing? So that have long-term damage.
Yeah, we have talked with the pulmonologists around us to also, when they see patients exactly how you described, and they don't find the cause being a lung problem, that they think of the heart next and send them over to a cardiologist.
Right. There are a few centers set up here in New York to work with long haulers, and their centers, you know, the centers focus on pulmonologists. Cardiologists aren't necessarily involved in that. So that's another big issue that needs to be tackled. Here's another question that came in. How significant are detectable cardiac changes in athletic people who had no previous comorbidities?
Who knows? The interesting thing, nobody knows. The interesting thing about that is, you know, we know there's this thing called the athlete's heart, where they have, you know, some hypertrophy because they've gone through intense exercise, and their physiology is not what you would consider, you know, normal, if you will. I mean, it's a normal variant, perhaps. And maybe that is what is a setup that we're seeing, you know, some of these, anywhere from 15 to 30% of these people having abnormalities when athletes are screened. But again, we're looking at very small numbers, right? So there's something going on there, perhaps, but you know, we don't have the controls. The more recent study on this with controls suggested that it really is specific to COVID, but again, based on very small numbers.
I'll add a very interesting little study from about 10 years ago with 60 some odd athletes. This is a study done in Calgary with with the group up there, they were interested in studying athletes. And they did MRI studies on these folks and reported the findings in these athletes who developed the common cold. So they catch the common cold. Now, they didn't break it down in terms of which virus it is, rhinovirus or the corona A viruses. They don't say. But they saw as much as 20% or more with some early versus late evidence for myocardial edema or inflammation based on MRI techniques that are 10 years old. Okay. And so there, it's obviously a preliminary study, but there's something interesting about that. And these were all athletes.
Yeah, thank you.
Athletes are interesting in two directions. I find the athletes highly interesting. One is that on one hand, because they're supernormal, they can tolerate abnormalities quite well, and they will compensate for it. And in general, younger people, fit people, compensate for some small damage relatively well. So we could say they're asymptomatic and they actually didn't have any problem, and we are overdoing it. On the other hand, the athletes immediately feel when they're not as fit as they used to be, and they fight against it. And this is interesting to raise. One is we have to stop them somehow from fighting against it, because even though we don't really know, my feeling is we're not doing them well if they keep on pushing themselves against a limit which is new for them. And the second is if someone who used to be 100 or 150% is now down to 99, 98 or 145, whatever, however you phrase it, that's not good. It may still be normal. They may still be healthy or even super healthy, but they're no longer as perfect as they were before. And I think this is something we should also take very seriously.
Well, that has long-term consequences for the individuals concerned. So,
in both directions, if we overdo it and if we underdo it. Yep.
Yeah, another question that came in, I saw this a few times. Our audience wanted to know what difference you saw between those who have recovered from COVID-19 versus those who would recover from annual influenza. It's not the same. We will start out by saying that it will stipulate COVID and flu are not the same. But what do you see in terms of heart damage to those who have had flu and recovered versus COVID?
I could give an answer from us. There is no large-scale systematic study after flu. I think COVID is better researched than most of the other diseases by now because we have so much going on. But what we do know is that in COVID, we see troponin increase, and that's a marker of cardiac damage in the acute phase very frequently. And in influenza, we don't see that. And that has been studied systematically. So in influenza, there seems to be less cardiac damage. And I do think we would by now have spotted it if the cardiac damage would be as high as in COVID, because in COVID, it didn't take long for us to spot it. Whereas in influenza, we have no systematic data, which just means it's not that prevalent.
Okay. Dr. Topol, Dr. Hu, do either one of you want to add to that?
I think that's summarized really well.
I think that's accurate. There's some very small numbers on the flu side, but really, really small in terms of troponin elevations.
So, so equating COVID-19 heart damage with any heart damage that would come around from the flu is really, it's a non-starter. They're not the same. They're not on the same plane. Would that be a good way to sum that up? Okay, we are out of time for the formal portion of the discussion, and a lot of questions have been coming in. So I'd like to shift to that as quickly as I can. For those of you in our audience who do have to leave, I want to thank you very much for joining us. And please, I also do want to thank our sponsors, remind everybody that we do have other salons coming up, in the future, and invite you to join us. And gentlemen, if you will indulge us, can we shift over to questions that have come in from the audience? Okay. Let me read this one to you. It's rather long, although I asked for them to be shortened. First of all, one of our viewers wants to thank you, Dr. Topol, for your August 31 open letter to the FDA commissioner, and to let you know that you've inspired much discussion. And a question.
We got that on track, by the way. It's a little footnote, but there may well have been a vaccine approved or given an announcement in October. So thank the FDA for holding tight and tightening the guidelines. And eventually it does relate to COVID and the heart, because next year we're going to get, population immunity achieved with these very high efficacy vaccines. 95% is unbelievable. It's fantastic. And so we will eventually, we might get the population immunity figured out better and achieved before we'll get the heart problem understood. That's the way this thing is moving. But the FDA deserves a lot of credit. If they had not developed a spine, this would have been a whole different look than it did, than it occurred. So thank whoever the questioner, appreciate it. Yeah.
I'll let you know later. So totally appreciate that. I think when the FDA seemed to be wavering, it frightened everybody in the industry. I come out of the biopharma industry. It frightened everybody. It would have been our reputation on the line. So a question for everybody: given the many uncertainties surrounding COVID, cardiac sequelae, how do you propose companies in the biopharma device diagnostic industry calibrate their businesses forecasts such that they do not get out of life-saving products? And that's a real business question. May not be the most appropriate, but if any of you want to dive into that. Okay. Okay, so this is all about supply chain. I don't think that's necessarily appropriate. So here's another one. Is there a difference between patients on ACE inhibitors or ARBs in terms of long COVID effects?
The studies that looked at that have not, although there was an initial connection between ACE inhibitors and ARBs with this COVID story, it fell apart. It's caved. There's no good relationship that's been established that I know. It's been studied pretty extensively, and it doesn't look like there's any untoward or beneficial effects of the medications with COVID and the heart that I know of. I don't know what you guys think. I haven't seen anything that would indicate otherwise.
From an acute treatment standpoint, I totally agree with Dr. Topol. I think the only thing I want to add is that ACE, of course, or drugs like ACE, is of course used in the long-term treatment of heart failure. So I also want to send out the message that, if your doctor says that you might need a drug like that because your heart's being damaged, that's probably still appropriate.
Oh, right. Absolutely.
Okay. Good message. Another question is, to what extent are there treatment options for patients diagnosed with these COVID-related heart impacts?
That's, again, a very difficult question, given that there are no randomized controlled trials what to do. Definitely what we know is that when patients develop heart failure, reduced pump function, they should get heart failure medication. That's approved and proven, and I don't think there's anything in COVID which should stop that. The question is if you can do anything in anti-inflammatory in the subacute phase, in the reconvalescence phase, and it at least looks like there's no damage if you do that. There was even no damage in giving steroids in the acute patients, so it doesn't look like immune modulation or immune suppression actually increases the virus load. And consequently, if you can reduce the immune response with this, there may be some benefit in it. But that's a maybe, because we don't have the trials. And without the trials, we don't know.
Right. Okay, one of our viewers to answer to your questions, what are the tools that are needed? What do you have? And would it be easier to fund the research through foundations rather than waiting for government?
Yes, that's why I asked about rich uncles and foundations. They move much faster. The cycles to go through NIH take many, many months. And by then, there'll be a lot of people that are not well. Yeah.
Okay, so I will get back to this particular questioner and let her know. In this case, it was her who asked the question. To Dr. Nagel, is the severity of cardiac changes related to the severity of prior COVID symptoms? Not quite sure I understand that.
I think it's probably, I would translate that if it's related to the severity of the acute disease.
Okay.
And no, shockingly not. The people who actually did really well during the acute phase can do really badly afterwards with their cardiac damage and vice versa. We, again, don't have enough data to fully answer that, but from the data we have, it's a rather no.
Okay, so another question, thank you for that. What hypotheses do you, about biochemical causation might be productive areas of early research? Too early to know, gentlemen? Okay. Another viewer said, and this is in answer to your call for, or I believe it was Dr. Nagel's call for a registry, doesn't the American Heart Association have a series of registry initiatives? Do they?
I'm not aware of one for COVID throughout the country, for COVID heart, that is. That would be a natural, but I haven't seen it.
Okay, we should follow up with them. Have you seen heart damage in young children? And if so, is the damage different?
There has been reports of myocarditis in young children. So the interesting thing is the multi-inflammatory syndrome of children, which is a Kawasaki's-like disease, but it's not the same as Kawasaki's. Fortunately, it's rare, but we have seen deaths in 6-year-olds, 8-year-olds from myocarditis with this MIS-C syndrome. So it occurs. It's different than what we've been talking about this hour in adults. It's a poorly understood syndrome, which is got autoimmune components, and it can occur after a child has already gotten better, and weeks or many days later. And interestingly, as opposed to Kawasaki's, it occurs in older kids more than younger children. And the heart is much more prominent than Kawasaki's. So when we think of Kawasaki's, we think of coronary artery aneurysms, and we don't think as much as myocarditis. Here, the COVID of the heart with children in this fortunately rare entity where there's hundreds of cases in the U.S. now, but that's a very small denominator when there's been 1 million children now infected, confirmed. So it's not common, but it's much more heart than Kawasaki's. Other viral myocarditis and involvement.
Right. Yeah. The balance of this question was that this particular questioner asked if the impact on children, the damaged children, is different than it is in adults, and I think you've just addressed that.
There is MIS-A as well, which is the multi-system inflammatory syndrome in adults, which actually the CDC actually just put out some data on. Not that many patients still, it's interesting that these MIS patients, many of them do not shed the viruses anymore. So PCR testing doesn't seem to pick up a big fraction of them, but the antibody testing does. And so it's a true, as Dr. Nagel had previously mentioned, it's a true kind of delayed effect that's not really related to the initial insult.
Okay, thank you. Here's a question that would relate to a very specific population. If the cardiac damage from COVID then leads a patient to, let me get back up here, to needing a heart transplant, have you seen that at all? And, and if a heart transplant is needed, will other potential comorbidities of COVID make that person less attractive of a candidate to receive a donor heart? None of you.
I believe that transplantation specialists.
Yeah,
there's been people with COVID heart put on transplant lists that I know of, but I'm not aware. Unlike with COVID lungs, where there's been double lung transplant, even in some young people, I'm not aware of any COVID heart transplant. There may well have been by now, but I haven't seen it published.
I didn't know that COVID in lungs had caused people to have transplants. But
I'm familiar with one young woman, I believe she was a nurse, who had a double lung transplant with COVID lungs, who was, in extremis. And that was widely reported, yeah. And there's probably been more since her, but I don't know of a heart transplant. I know of a patient who was 36, Hispanic, in Florida that I was consulted on, who almost, wound up with a heart transplant, but he's wound up with a very severe cardiomyopathy and is medically managed. But he's basically he was a coach in a elementary school, phys ed, and he can't even walk a block now. That's with meds, but fortunately he averted a transplant.
Mm-hmm.
If you look at the viral, if you look at just the myocarditis, take a step back and look at the myocarditis literature, and you look at dilated cardiomyopathy, I believe there's really a landmark study back about 10 years or so ago by Kuhl. Is it Hamburg? It's close to you, Ike? Where they biopsied everybody basically who had unexplained dilated cardiomyopathy, found something like 70% of them have viruses. And that has been really the focus of a lot of the research now in terms of dilated cardiomyopathy. And of course, a large fraction of those folks, were candidates eventually for heart transplantation. So, there's definitely reason to think that, this is a condition where it might lead to something similar.
Right.
The causal direction between having a virus in the heart and getting cardiomyopathy has not been established. It may well be the immune response to the virus which causes the damage, which is the longer term problem. And I would focus more on that one than the acute. I mean, the acute damages, you have to focus on those, but for the long term damage, I would tend to focus more on the autoimmune damage.
Right. Thank you. Again, another question coming from the person that asked the question about foundation support. Which research platforms must be established and funded to translate new knowledge of post-COVID-19 cardiac consequences to optimal patient care?
So definitely you would need highly standardized, in-depth analysis, if you focus on the heart, at least of the cardiac issues. That should not be techniques which it should not be echo, for example. It should be something which goes more in depth, looks at the heart muscle, at the myocardium directly. I'm obviously biased towards MRI, but I think it's the perfect tool to do this because you get so much information in a short examination. It needs to be shortened. That's why we work together with Dr. Hu on these standardized, very short automated scans, because then you can use it not only to characterize patients when they come in, but you can also do the follow-up in them. We also do scans which last 10, 15 minutes for follow-up. And that's something you can do with a lot of people. You can screen people, you can get a high volume through. I think that would be, for me, the most important platform. and the rest is exchange data in a standardized form, make sure it's documented well and quantified well.
Okay. Dr. Hu, do you want to add to that? You look poised to say something.
Yeah, I might just add a little piece to that, which is that, why not echoes, right? Because that's certainly one of the questions that people will ask. And I think the answer is that a lot of people, echoes doesn't give you the tissue discriminative ability of MRI. And so if you just look at whether the heart is beating properly, if you will, which is echo is very good at, of course, we're going to miss a lot of folks. And that's, I think, one of the concerns with that.
Okay.
The other thing to add is the blood. To have the proteomics, have the genomics to understand the patients. That would be also important.
Okay, Dr. Topol?
Yeah, I'm going to have to excuse myself here. I got to go. Yeah, excuse me.
Okay. Okay, thank you very much. Okay, so then a final question is, in anticipation of studies to look at the treatment of patients exhibiting chronic cardiac damage due to or correlated with COVID infection, what do you believe would be the relevant endpoints? CMRI improvement, changes in circulating troponin levels, or other?
Long term, it must be outcome, because we need to prove that whatever we do helps people to live longer and live better. For shorter term studies, it needs to be MRI, not troponin, because for troponin, we don't know exactly where it comes from. With MRI, we can see, as Dr. Hu has just said, we can look into the tissue, we can see the amount of inflammation, the amount of fibrosis, and the function very well. So that gives us a short-term answer to the direction patients are taking. But we do need long-term follow-up for prognosis. Okay.
Dr. Hu, did you want to add anything?
No, I'm in complete agreement. Outcomes is really, from a long-term standpoint, what, we as physicians, obviously, that's the ultimate measure of what we do. So.
Okay. All right. I think there are more questions, but I think we have come against our time to wrap this up. With that said, I'd like to thank both of you for joining us. I will send a note to Dr. Topol to thank him independently. And thank you for the very timely discussion. I don't think before we had this discussion that I realized that there was such a paucity of funding going into research to look at the damage to the heart due to COVID. And I think that's something that we can write about as we prepare our follow-up, to this particular salon. So thank you very much for joining us, gentlemen. And for those of you who are with us, thank you for joining us as well. I'd like to thank our sponsors for supporting us consistently throughout this challenging time. And our next virtual salon will be on December 9th, and it will focus on how U.S. policy and trends will shape healthcare in 2021. Our discussion today was relevant to that future discussion. Gentlemen, thank you very much. Thank you. Signing off.
Thank you.
Bye.